Committee on Health and Human Services Finance will come to order. Representative Heintzeman moves approval of minutes from March 16th. Any additions or corrections? Seeing no additions and corrections, all those in favor of adoption of the minutes from March 16th, please say aye. Aye. Those opposed, no. Minutes are adopted. First up, we have House File 2304. Representative Franson moves House File 2304 be laid over for possible inclusion in the Health and Human Services Omnibus Bill. Members will note that there is a fiscal note with no change and there are no amendments. Representative Franson to House File 2304.
Thank you, Mr. Chairman and members. As the rate of medical advancement continues to grow, we must occasionally work with regulators to ensure that proven technology is not prohibited in our state. House File 2304 addresses an X-ray technology currently used in all but 3 states, Minnesota being one. Although Minnesota doesn't strictly prohibit the device, the paperwork associated with its use makes its use all but impossible. My simple goal with this bill is to allow dentists who would like to use this device a way to do so. We have been working with the department, and this language represents our conversations thus far. That completes my bill.
All right, thank you. I see you have some testifiers to answer questions. Are there any, is there anybody else in the audience who'd like to testify in this bill? Okay. All right. Perhaps to your testifiers, Representative Franson, if you just want to briefly introduce yourself and just give a quick synopsis. Welcome to the committee.
Thank you, Mr. Chairman. My name is Scott Haddon. I'm with the Rebex. I'm a representative manufacturer that manufactures handheld battery-operated dental X-ray devices. First off, we'd like to thank the Health and Human Services Department. It's been very nice working with them in putting together this bill. As Representative Franson has said, this is a new innovative technology that is more efficient for clinicians. It provides less radiation dose to the patients, and it's safe for the hygienists and operators. So it has a lot of things that are beneficial for the clinicians that we just don't, we can't provide to them. And so to keep that short, that would be probably the bulk of my testimony, unless I have some questions from the other representatives.
All right, Representative Pinto.
Thank you, Mr. Chair. And I just wanted confirmation. We've spoken about this, that the Department of Health is supportive of this change.
That is correct.
Thank you.
Thanks. Other questions for the testifier? Would this, the advantages of this obviously are that it's mobile. Is this better for people who have difficulty moving around, or disabled people, or old people, or is that one of the primary advantages?
That would be one of the advantages. It obviously makes it easier to take the care to the patient, and we do that quite regularly in humanitarian missions that we support worldwide. Additionally, though, for the clinician themselves, it's about 30% faster to do a normal imaging series using this device than with using a wall mount. And specifically, the reason why is that the operator has to walk out of the room with the traditional wall mount. With this device, they stay with the patient, it safely protects them, and they're able to just continue to shoot in sequence, and it saves them time. So it's a benefit to the clinician, and then also a lower dose to the patient.
Makes sense. All right, thank you. Other questions? Seeing no other questions, thank you, Representative Franson. House File 2304 is laid over for possible inclusion in our Health and Human Services Omnibus Bill. Next up, we have House File 2150, Representative Anselmo. Has he been here before? Okay. All right, next up, we'll have a Hamilton bill. We'll wait for Representative Anselmo is in another committee making his way here, so we'll make contact with him. And in the meantime, where is he? Oh, there he is. Representative Anselmo, welcome. All right. Welcome to the committee, Representative Anselmo. Representative Anselmo moves House File 2150 be laid over for possible inclusion in our Health and Human Services Omnibus Bill. The bill is before us. I don't see any amendments in the packet. Members will note that there is a fiscal note in the packet. Representative Anselmo to House File 2150.
Thank you, Chair and committee. I'm here today to speak about House File 2150. This is the bill that will deal with funding for the future for Clearways to help with smoking cessation. Each year, tobacco takes the lives of over 6,300 Minnesotans and costs our state over $3 billion. Clearway, Minnesota currently funds the operations of quitline services, which is what this bill talks to. Because Clearways will end in 2023 when the tobacco bonds expire, the safety net that the quitline runs will end in 2020. So we're seeking funding for that in years going forward. Other states actually have quitlines that are run by the states for these quitlines. In fact, Minnesota is only one of 2 states that is not funding their own quitline services right now currently. Right now, we're looking to seek $350,000 in fiscal year 18, and looking at $2.85 million in fiscal year 19. I'm going to introduce Molly Mullany from Clearways to talk more about this bill.
Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair and committee members. For the record, my name is Molly Moylanen, and I work for Clearway, Minnesota. I'd like to thank Representative Anselmo for authoring this proposal, and for thank Representatives Schumacher, Halverson, and Schultz for also lending their support on the bill. Clearway, Minnesota is an independent nonprofit organization funded with 3% of Minnesota's tobacco settlement. Our mission is to enhance life in Minnesota by reducing tobacco use and exposure to secondhand smoke through research, action, and collaboration. We were established as a limited life organization, and we will sunset by January 1st of 2023. Since 2001, we have operated quitline services. These are effective, science-based programs that give Minnesota tobacco users free tools to quit. Quitline services includes phone counseling, medications, emails, text messages, and other self-help materials. Quitline has provided more than 160,000 Minnesotans with quit smoking help. Last year, over 15,000 Minnesotans enrolled, and thousands more contacted us for basic information on smoking cessation. Quitline will end in 2020. This bill allocates funds to ensure Minnesota's tobacco cessation safety net remains after quitline ends. Smoking remains the #1 cause of preventable death and disease in Minnesota, and as Representative Anselmo said, tobacco takes a tremendous toll in lives and money in Minnesota, across the country, and around the world. We know that 7 out of 10 adult smokers want to quit, and about half make at least one quit attempt each year. Helping them is one of the most cost-effective health services we can provide. Research shows that costs of smoking cessation programs can be fully offset in just 3 years. The funding in the bill would pay for direct services and clinic referrals provided by a professional third-party vendor. There are also dollars for promotion and for evaluation to ensure quality. Planning funds are needed in fiscal year 18 and full funding in 19. This timing would be ideal to avoid gaps in cessation coverage for those who need it. It's kind of like a track relay. When you're running and you have to hand off that baton, the runner in front of you has to start running to match your speed so you can have an efficient and a smooth handoff as you slow down. It's been our honor to help people quit through quitline services, and it's in all Minnesotans' best interest for this work to continue because it will save money and lives. Thank you.
All right, thank you for your testimony. Is there anyone else in the audience who'd like to testify on this bill? All right, seeing none, member questions? Seeing none, House File 2150 is laid over for possible inclusion. Thank you to the testifier and to Representative Anselmo. We appreciate it.
Thank you, Chair, and thank you, committee.
Thank you.
All right. This one? Where's Baker? There he is. All right. House File 770, Representative Baker moves House File 770 be held over for possible inclusion in the Health and Human Services Omnibus Bill. Representative, I see an A3 that will not be offered, is that correct?
That is correct.
All right. Welcome to the committee, Representative Baker. I moved House File 770, so it is before us. Please proceed in whatever way you'd like.
Thank you, Mr. Chair and members. Today I bring you House File 770, which is, it's kind of a way to try to make it easier for another treatment for this horrible opioid crisis that so many of you have heard about. I've lived it, and I want to make sure that we allow more providers the ability to use a drug called Vivitrol. Vivitrol is a injectable, medically assisted treatment that helps put a blocker on the brain for 30 days. So it's not for everybody. It's more expensive to administer this than it would be some other opportunities, but it is a very good option if a provider, if a doctor thinks this is right for this patient. So with me today, members, I have a couple of testifiers that can actually speak to this better than I can, but I am wholeheartedly behind this kind of medicine that will help more people become in a better life, more sobriety, that kind of thing. So with that, Mr. Chair, I'll turn over to my testifiers.
Welcome to the committee. Please introduce yourself for the record and proceed in any order you'd like.
Thank you, Mr. Chair and members. My name is Bahr. Excuse me a second. My name is Bahr. I'm the Executive Director for the MARCH Association. MARCH stands for Minnesota Association of Resources for Recovery and Chemical Health and represents 80 organizations and about 2,500 addiction professionals from around Minnesota. I'm here today to offer our support of HF 770, which we believe would improve access to non-narcotic, non-addictive injectable forms of medication-assisted treatment, such as Vivitrol. I'd like to thank again Representative Baker for his support for this bill and for his overall support for improving addiction care in Minnesota. And I'll keep my comments brief. The March Board of Governors and I recognize the importance of modernizing and integrating Minnesota's addiction care system while removing barriers that prevent our citizens from receiving immediate access to quality care options. The March Board and I believe that system reform involving a menu of research-based options to effectively treat addiction is critical to addressing this growing public health concern. The buy-and-bill mandate does restrict access and creates a barrier for providing Vivitrol as an efficacious treatment option. As Minnesota is in the midst of an opioid epidemic with no signs of slowing down, it's critical that we change state policies for better access to innovative treatment options and look at ways to better manage the disease of addiction. Mr. Chair, that concludes my remarks. Thank you.
Thank you for your testimony. Welcome to the committee, sir. Please introduce yourself.
Yeah, I'm Dr. Thomas Weingarten. I'm a board-certified psychiatrist, board-certified addiction psychiatrist from Chanhassen, Minnesota, and I've worked in this field for 25 years. I've sent over 50,000 people to recovery. I have lots of experience with this medication, and I'm a huge advocate of it because, again, it's been one of the most safe things we can possibly do, saves a lot of lives, and this current way they make it available makes a huge barrier for me to get it. So again, naltrexone is an opiate antagonist. It means you can't, if you take opiates, nothing happens. So it doesn't just block the brain, it also stops you from stop breathing in your lungs, because that's what kills people. It also is indicated for alcohol craving. And what's interesting about that, if you drink alcohol, it triggers all the other drugs that you can use. So if you're an opiate addict and you drink, you're way more likely to relapse on opiates. So again, this medicine stops craving. Here's an example. I had a lady a dozen years ago. She had 60 WIs, 50-year-old lady, master's degree, lovely lady, but an alcoholic who was depressed. I got her on this shot. She said, for the first time in my life, I didn't crave. She said, I've been craving alcohol since I was 9 years old. She said, because I didn't crave, I stayed in treatment long enough to get the medicine you gave. I'm an addiction psychiatrist. 85% of the people that relapse have an untreated mental health issue, and 1 in 5 of those people commit suicide. So it's 50,000 people, 10,000 are dead, but 40,000 aren't. This lady's still around because that medicine, and then I got her on the right psych meds. Here's the thing. Again, she got her license back. I helped her get it because she never drank and drove. She would drive her car to the end of the road, pull off the side of the road, turn the car off, take the keys out, and drink because she was too damn anxious to drink in a bar and she couldn't drink at home. The medicine helped her stop doing that, and now she's not so anxious. She uses her license to drive people to meetings. She takes the bus to work. She knows that was her bar. You can't do sober when you're drunk. This medicine helps people not be drunk, but also helps people not use opiates. So here's, fast forward. I could get that medicine back then 12 years ago. Now I can't because it's buy and bill. It means I have to spend $1,000 out of my pocket. If the patient comes in, I give it to them, I can apply to get it back, but if they don't show up, I eat $1,000. Now, I was a minister, I've been a lot of things, I don't have a lot of money, and that's not a way I want to spend it. Patient comes in, 19-year-old, try to get him in treatment, he didn't want to stay, he left, he used, got arrested, put 4 months in jail, his dealer picked him up, brought him to the place, shot him up, and he overdosed and would have died, but the dealer gave him a shot of Narcan, which is similar to what this is. He started breathing, and he dumped on my doorstep. I showed up at my office at 7 in the morning. There's this guy laying there on the beach. Anyways, I gave him, got him in the hospital, tried to commit him. They said, well, he says he'll go to treatment. I said, he'll never make it. Now, if I could have given that shot, I would have, but I couldn't. He went to treatment. 4 days later, he overdosed and died. Here's the point. You guys can talk about cost. I get it. A half day in the hospital, $2,000 a day, pays for this shot. How many treatments aren't we going to have? How many times are we going to not have them in the hospital? How many people are not going to be dead because we can spend something? This isn't about drug money. This is about getting people the right care. An addict has a brain that says, this gets me out of it, I do it. And I know, I'll turn it off. That this gets me out of it, I do it. You take this naltrexone in an oral form, and it lasts less than 12 hours. So guess what? They don't take it the next day, and they're already using. That's the problem. This comes and stays in their system for a month. When you first show up at treatment, less than 3% of your cognitive function is working. At 3 months, it's 30%. How are you going to fight that big reptile brain that says, this gets me out of it, when you only have 3% to do it? This medicine helps people actually do that. So I could go on and on. Sorry, but again, I watch people die every day. I watch people live every day and celebrate it. I think this medicine helps us. This cumbersome method of buy and bill has really interfered with lots of people's lives. Thank you.
Thank you. Representative Murphy.
Thanks, Mr. Chair. We heard this in the Reform Committee, and we voted for it, of course, because I think people are in support of the idea that there should be more access to the remedy that you're describing. But there were also questions and concerns in that committee about the relationship between the supplier, the pharmaceutical company, and the pharmacies, and then access on the part of people who need to use the drug, and that relationship and transparency around that relationship. I will tell you, I hear not a lot here at the legislature, but concern expressed, especially when I get into meetings where we're talking about the opioid crisis, and some suggesting that one of the reasons why we have this problem is because there's been so much access to the drug from the pharmaceutical companies. We've made it pretty available. So I know, Representative Baker, that you had heard committee members asking those questions and wanted to try and tackle that issue. And I see your amendment, but you're not offering it. So I'm just wondering if you can fill us in on where we were, and maybe we need to have DHS come down and share their point of view as well. Thank you.
Representative Baker.
Mr. Chair, Representative Murphy, that's an excellent question. I was going to give some explanation to that. The amendment, I was actually visiting with stakeholders over the weekend trying to make it right. We're not quite there yet. And I will tell you this, that the department, I'm sure, is willing to come down and answer some questions. Here's what's happening. In just 2 days from now, we're actually having a meeting with the department and with the manufacturer and or the docs to make sure that we can do this right, that works with everybody. We're just not quite there yet. So I didn't want to enter something that I didn't feel like we just totally were there yet. So saying that, I think everybody is in agreement this is the right thing to do. We just got to find the right method to get the buy-in bill tweaked enough so it doesn't cause other things to have negative effects on what they're trying to do. You know, there were some comments in the reform meeting about what about wasted dosages and other things like that. They're still trying to work those tweaks out because we don't want to have any wasted dosages. This dose that you would get is the same for me as it would be for you, Representative Murphy, and you're half the size I am. So these are not so much of like oncology and very specialized to each person's makeup. So we're trying to work that out. Thank you for that question, and I am extremely committed to making sure that this is going to work right for the department, really foremost in this, to make sure that we can do this properly.
And Mr. Chair, and Representative Baker, do you think that that negotiation that you're having will be completed in time for the omnibus bill if this is included in the bill?
Representative Baker.
Mr. Chair, yes, I do.
And then, Mr. Chair, I don't need to have the department come down unless they have something additional to add to that. And I will take Representative Baker on his word, of course, that he is working with the department and the stakeholders to work that out.
Thank you. Other questions?
Thank you,
All
Mr.
right.
Chair.
Thank you. Thank you, Representative Baker. And with that, House File 770 is held over for possible inclusion in the Health and Human Services Omnibus Bill. Thank you to the testifiers as well. Let's see, Representative Bennett. There she is. Representative Bennett moves House File 986 for possible inclusion in the Health and Human Services Omnibus Bill. Members will note a fiscal note in the packet. No amendments. Representative Bennett, House File 986 is before the committee, and so are you. Welcome.
Thank you, Mr. Chair and members, for having us here. I'm excited about these bills because both of these have to do with a very important subject of our foster homes and our foster care children. So this first, House File 986. Right now, there's this, well, I'm getting ahead of myself here. Let me explain what it is, first of all. We want to provide insurance to individuals licensed as foster care home providers to cover their liability for injuries and property damage, and also this increases the limit for this. So this provision actually adds cover for foster parent property to liability insurance that foster parents receive from the state. Many youth who are removed from their families and placed into foster care experience abuse and neglect and have long histories of trauma. Some of these youth are wary of trusting adults and have learned survival techniques that can lead to acting out, and that includes destruction of property. So there are many stories of dedicated foster parents who hang in there with these children, and they stick with those kids until the kids can feel safe and the parents are able to teach them new ways of dealing with fear and frustration. Even if the foster parent has a homeowner's policy that would cover this kind of damage to their property, most have at least a $1,000 deductible. So we ask a lot of our foster parents, and I don't think we should be asking them to bear these kinds of costs that they might incur. And Mr. Chair, I do have a testifier.
All right. If your testifier wants to come forward.
I guess she says that we're good to go here, so.
We're good to
Save
go.
you some time,
All right.
Mr. Chair. Any questions, Mr.
All right.
Chair?
Does anyone else in the audience want to testify on House File 986? Seeing none, member questions? Seeing no member questions, House File 986 is held over for possible inclusion in the Health and Human Services Omnibus Bill. Thank you. House File 987, Representative Bennett. I will move House File 987 be held over for possible inclusion in the Health and Human Services Omnibus Bill. There are no amendments. There is a fiscal note. Representative Bennett to House File 987.
Thank you, Mr. Chair and members, and we'll try to make this one go quite as easy as the last one. I know you have a lot on your plate today. This bill would require a responsible social service agency to provide foster care and services to individuals who are over 18 but under 21 years of age. Just to give you a little background in this. In 2008, President George W. Bush signed into law the Fostering Connections to Adoption and Success Act. This provided, among other things, federal funding for youth ages 18 to 21 for extended foster care, independent living settings and services. Minnesota has implemented many of these provisions in this act, but does limit the opportunity for youth who age out. These youth who age out of care, who might want to opt back in. So far, if they're awarded the state, they are able to do that. But if they are not awarded the state, but in the foster care system, they are not able to do this. This bill extends the option to return for support to all youth who age out without a permanent reliable family if they meet the federal eligibility requirements. We have removed these young people from their families and taken on the responsibility to parent them. And as we all know, as parents, good parenting doesn't stop at age 18. And Mr. Chair, now I really do have a testifier for this bill.
Welcome to the committee. Please introduce yourself for the record. And please, obviously, we do have a lot of bills, so try to be brief, and for other testifiers as well. We do need to move quickly through a lot of bills, but please don't hesitate to testify. And also, members, please don't hesitate to ask questions and make sure that we get through the content so that everybody's satisfied to move the bill. Welcome to the committee. Please introduce yourself and proceed.
Thank you. My name is Joan Wiebel. I'm the Executive Director of Family Alternatives, a private nonprofit foster care agency that's been in existence for 39 years. We've fostered a little over 10,000 young people in our existence. I was here a couple of weeks ago to tell you a story about Michael, a young man who survived abuse and neglect as a young boy and a subsequent failed adoption. He did well in foster care and graduated from high school at age 18. He left for 2 months to try and connect with his biological father in Florida. That was not successful, and he returned to Minnesota with our help. Because his adoptive parents' parental rights were never terminated, he was not awarded the state and thus was unable to re-enter foster care. He ended up homeless, and today he's in St. Cloud Prison for assault and battery. If you remember this story, I'm sure it tugs on your heart as it does mine. Children enter foster care under difficult circumstances, with the deck often stacked against them. As adolescents, they often dream of being on their own, away from the system that supports and monitors them. When they turn 18, they have that option. As you can imagine, that leaving with the supports and services cut off is an abrupt awakening. Excuse me. If they are wards of the state, they have the option of re-entering, getting housing, medical care, and school stipends. If they're not wards of the state, that option is not available to them. Can you imagine an 18-year-old, especially one who's had a challenging childhood, making it on their own? Statistically, these kids face many challenges. Many try unsuccessfully to unite with their families. Many end up homeless, incarcerated, or physically and sexually victimized. As a policy issue, statistics show that they cost us more as homeless young adults out of the system than they do as kids in care. I could tell you so many stories. Mary, a successful student, was 18 when her foster mom died of breast cancer. She was very attached to her, and in her grief, she left care to live with a boyfriend. The relationship was short-lived. She could not re-enter foster care because she was not awarded the state. By age 21, she was a single mother of 2, had not finished high school, and was asking us for money to feed her babies. Donald left care to live with a girlfriend as well. Again, short-lived, and he's now homeless and living on the streets. The kids who are able to stay in care until 21 have so many opportunities in those 3 years. Alex has an apartment at Nicollet Square, and he's in his 2nd year at MCTC. Mara is still living with her foster family and going to college in Michigan. We've had kids at St. Ben's, St. John's, Clemson, the University of Minnesota, Dunwoody, and a variety of community colleges. All of them had foster families they could return to while on break in the summer, or sometimes just to wash their clothes. Wouldn't it be wonderful if all of our most vulnerable young people could have these options? The other stories tug at my heart because I know it could be different. Kids are in foster care through no fault of their own. They need the safety net of financial, social, and emotional support well into their adulthood. Thank you.
Thank you for your testimony. Is anyone in the audience want to testify on this bill? All right, we'll close that. Member questions? Representative Liebling.
Thank you, Mr. Chair. And Representative Bennett, I so agree with you on the underlying principle here. And we've discussed this at other times, and I think this is absolutely wonderful to allow young people to come back into foster care, to completely support that. But I have a little bit of a question from the fiscal note. And the amount here on the fiscal note is really a very low number, which is usually a great sign. But as I was reading the narrative a little bit, I'm seeing that the reason that the number is so low is they're saying, and this is on page 4 of the fiscal note, that through various calculations they've done, it's assumed that no more than 35 youth would reenter foster care per year as a result of the bill. And what the bill is really doing is giving them a right to go back to foster care, as I'm understanding it, and you're attempting to pay for that, which is great. I mean, the state should pay for that because this is county. It falls to counties otherwise, as I'm understanding it. So my question is, I mean, I think, if it's no more than 35 youth, as it's assumed here, then the bill, that's why you've got this wonderful low fiscal note. But, so if some money is appropriated, I'm wondering whether there might be a concern that more young people would, as word spreads, which would be a great problem to have, that more young people would want to use this. And then, as I'm understanding it, probably that cost would fall to the counties. So I'm just a little bit concerned about whether the appropriation is really going to be adequate for the need. I mean, I sure hope it will. I know we're all really sensitive about putting more costs on our county property taxpayers. And so I guess what I'm really asking is, have you had any conversation with the counties about what will happen if this isn't really an adequate appropriation for this?
Representative Bennett.
Thank you, Mr. Chair, and thank you, Representative Liebling. Good question. That specific question, I haven't asked them. I mean, my part, I do not want to put added burdens on our counties. They have plenty already. And I guess my gut instinct is to follow the fiscal note because they've made their best judgment. From what I understand, not a lot of children need this, and many of them are already wards of the state and they're already covered. These are for the few that aren't wards of the state and still need that additional support from those foster families. So I guess if we do see an increased amount, that's something we will need to deal with in the future. But at this time, I would like to trust the fiscal note and hope that we will cover those young people that need it. And if we end up needing more, then let's address that in the future.
Right. Mr. Chair.
Representative Liebling.
Thank you, Mr. Chair, and thank you, Representative Bennett. I also would like to trust the fiscal note, and I guess I would just ask you, I hope we can fund this. I hope we can move it forward. I think it's very, very important. I guess I would just ask you, as the author of this bill, to kind of keep your eyes on that and maybe stay updated on how many young people are actually using it, so that, and I'm sure the counties will too, and that, if it turns out that more money is needed to make sure that doesn't just fall to the counties, that we can hopefully step up and do that at the state level, because really, I think this is another one of those things that has the promise of saving costs down the line, in addition to being a really important thing to do for these young people who, after all, are kind of the state's children in a very real sense, right? When somebody's a ward of the state, they are our child. And I think it's really important for us to step up and take care of them until they really are able to do so on their own. So, thank you.
All right, other questions? Seeing no other questions, House File 987 is held over for possible inclusion in our Health and Human Services Omnibus Bill. Thank you, Representative Bennett.
Thank you, Mr. Chair and Committee, and Representative Liebling. I will keep that in mind and circle back on that.
All right. Next up, House File 1714, Representative Hamilton. Representative Zerwas will move House File 1714 be held over for possible inclusion in the Health and Human Services Omnibus Bill. House File 1714 is before us. Representative Zerwas to House File 1714.
Thank you, Mr. Chair. Members, unfortunately, Representative Hamilton is out at a funeral today and asked me to step in and present House File 1714 on youth sports concussion to the committee. In 2011, Minnesota enacted youth sports concussion law. This proposed bill will create a working group to study the effects of that law, and will also support a pilot project to foster innovation in concussion prevention, detention, and care. The working group report and pilot project results will foster development of a Minnesota model for preventing, identifying, evaluating, and treating youth sports concussions. The study will create no new reporting requirements and no new administrative regulations. Mr. Chair and members, there are two testifiers here today, Dr. Franson Shen and Kayla Meyer.
Welcome to the committee. Dr. Shen, please introduce yourself and proceed.
Good afternoon, Chairman Dean and members of the committee. Thank you, Representative Zerwas. My name is Franson Shen. I'm a professor of law and neuroscience at the University of Minnesota Law School, here to testify in support of HF 1714. As the representative said, this bill is about accountability and innovation. In 2011, this legislature passed a law changing the way that the state handles youth sports concussions. And we don't know how that law is working or if it can work better. This bill will allow us to go out and replace anecdote with evidence and data, come back to you with that information so we can reform or, as needed, refine the law. The other thing that this bill is about is innovation. A lot has been learned about traumatic brain injury since 2011, and a lot of that knowledge has come from right here in Minnesota. To give you just a sense, at Mayo Medical Clinic, they are developing new biomarkers for sports concussions. Hennepin County Medical Center is developing new eye tracking technology for use on the sidelines. At my institution, University of Minnesota, Gopher Athletics is at the cutting edge of concussion treatment and prevention, and we're using the, not an exaggeration, the most powerful brain scanners in the world to try and understand what exactly is going on inside the brain during a brain injury. There's much more going on. Project Brain Safe, Center Care in St. Cloud is doing great work, Sanford Health and other parts of the state. So many, our idea here is to allow youth organizations and schools which would not otherwise have such an opportunity to partner with these innovators through a series of one-time grants, again, to look for ways that we can take the national lead in addressing youth sports concussions. I just want to give you a sense of how big a deal this is. Last week at a meeting with the Big Ten Ivy League collaboration, this is the smartest folks in the country working on sports concussions at the NCAA level. They told me they were aware of no state that's trying to do what we're doing at the youth level. This would be a big deal. And again, to emphasize, this does not change the actual law. It creates no new reporting requirements, no new regulations. It'd be an entirely voluntary study. And in closing, I simply want to note that we're a grassroots effort. We have no paid lobbyists. You'll note, however, that we have a lot of grassroots support, signatories, over 40. It's almost doubled in the last 2 weeks. Some professional athletes, Ben Utek, Chad Greenway, both of which would have been here today except they're out of the state, and many others. So in our view, I think in the view of many, it's a no-brainer. We ought to tackle youth sports concussions, and I'll turn the floor over to Kayla Meyer. Her journey reminds us why this is so important.
Welcome to the committee, Ms. Meyer. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair and members of the committee. My name is Kayla Meyer, and I have a mild traumatic brain injury from 2 concussions that were 10 months apart in hockey. My injury was 7 years ago, but I still suffer from daily symptoms, including sensitivity to noise, sunlight, vibration. Every step I take, it causes pain in my head. I have a sensitive scalp and sleep issues. It hurts to lay on my pillow, and I'm required to take medications. I suffer from fatigue. And for the past 7 years, I've had a constant headache for every second of every minute of every hour of every day. I've been to 10 neurologists, 13 physical therapists, 2 acupuncturists, 4 chiropractors. I've been to Mayo Clinic, Bethesda Hospital, Hennepin County Medical Center, Naran Neurological Clinic, and many more in between. I've had MRIs, CAT scans, steroid injections, nerve blocks, Botox, and drug infusions. My medication list is 13 pages long, and my pharmacist knows me on a first-name basis. I'm a junior at Minnesota State University, Mankato, and I'm registered through Accessibility Resources. This gives me extra time to take tests. I have a note taker. I get to sign up for classes before the rest of my peers. And I also introduce myself at the beginning of every semester to each one of my professors to tell them that even though I look okay on the outside, I'm not okay on the inside. I speak on behalf of the Minnesota Brain Injury Alliance across the state to youth to tell them to take care of their brains, that youth have a longer recovery time than most other people who suffer from concussions, and if they have a concussion, they're more likely to suffer from another one. I urge them to wear a helmet, whether they're on the rink, the field, skateboarding, riding their bike, or riding their horse. They only have one brain, and they have to take care of it for the rest of their lives. I can no longer play the sport I loved, hockey, the sport I played for 10 years. I don't want what happened to me to happen to somebody else. We've come a long way since my injury 7 years ago, and the return to play bill that was passed here in 2011 that I testified for on 3 separate occasions helped with that. With House File 1714, we can continue on that path of progress by showing Minnesotans we want to protect the brains and futures of our youth athletes. I highly support this bill. My name is Kayla Meyer. I suffered 2 concussions, and this is my life.
Thank you, Ms. Meyer, for your testimony. Is there anyone else in the audience who'd like to testify on this bill? Seeing none, member questions. Representative Lunan.
Thank you, Mr. Chairman. And to the gentleman from the U, what role does companies like Rydell and Kramer play in these programs? Are they involved also?
They're not yet involved, but there is a group, there are multiple groups examining, for instance, football helmet safety. There's a group at Sanford Health, the southwest part of the state, that's working with various manufacturers to look at those issues. So they haven't been directly involved. We haven't spoken with them, but one of the ideas would be to go out and, for instance, just simply catalog the sorts of equipment that's being used, the variation, the age, and to line that up with, say, what's happening at the Gophers arena, which are the cutting edge. So at present, we haven't had those conversations, but that would certainly be a part of the project to have.
Representative Luna.
Well, Mr. Chairman, I think some of these studies are already going on from a product liability standpoint from these manufacturers. Our former football coach in Shakopee was one of the point persons in high school football in developing a different helmet, and was able to access all kinds of information from the different types of manufacturers for the sports equipment.
Representative Liebling.
Thank you, Mr. Chair, and Dr. Shen and Ms. Meyer, thank you very much for being here and doing this, and I think it's a great idea. And I just have one concern. I had raised a question in the previous committee about the wording about where these pilot programs are, and I had had an amendment drafted and had talked to Representative Hamilton. It's unfortunate he's not here. Ms. Clark-Fisk, did you have a copy of that for me? Okay, so anyway, I had emailed with Representative Hamilton, and he was gonna, I had an amendment, and he was gonna offer it just to straighten out the language a little bit, and I don't think that happened. I'm not sure why, but I just wanted to flag that. If you could just kind of talk a little bit about the language on page 3 about where the pilot programs are intended to be. You know, I thought the intention was that there would be at least 4 pilot programs in different areas of the state. Am I correct about that? And
yes, and I remember your question, and I apologize that we don't have that amendment. It might have been because the representative is away today. I wasn't aware that you had sent that around. But our intention is to ensure regional diversity, and we're open to wording that we had proposed 5 programs and said that, and just that maybe it's a terminology issue, and this was my own wording to try and say essentially the 4 categories that would cover the entire state, and then a 5th that could go anywhere, and we're open to certainly amendment on that issue. Our intention is simply to ensure our regional diversity. And I'll say that the reason for that is there's been one study by the DHS on concussion incidents. It included only 33 schools, and all those schools were from the Twin Cities area. We have partners from Greater Minnesota, and we have a strong interest in understanding this, not just from a Twin Cities perspective.
Yeah.
Representative Liebling.
Thank you, Mr. Chair, and I won't belabor it now, but, Ms. Clarkfist just gave me a copy of the amendment, and, I could just show it to you, but, this, we can deal with this later on,
Yeah.
and of course, Representative Hamilton isn't here. But I had just noticed in the language that it looks like my area, which is southeast Minnesota, isn't included, and I know that wasn't your intent, so, I think we just need to make sure that we straighten out the language here so that it's
Yes.
clear what you're intending to have
We'd be happy to
happen.
do that. That'd be great.
Okay, thank you.
Yep, and Representative Liebling, if you wouldn't mind just shooting Ms. Iverson a copy of that, we'll make sure that we have it when we're constructing the omnibus bill. Representative Albright.
Thank you, Mr. Chair. And this question is for Ms. Meyer. So I don't want to, just briefly, but you said you had 2 concussions within the space of a certain number of
10 months.
10 months. Can you describe the severity of each concussion and what type of recovery you went through and what type of preventative steps you took in the interim before your second concussion?
Yeah, absolutely. So my first concussion was when I was still playing 12U. It was during a practice with my team, and I slipped on the ice and I landed on my head like this from about 3 or 4 feet up. And for that one, I went and had an MRI, and they said I almost had a concussion, but knowing what we know now, we're pretty sure it was a concussion, and I was only out for 3 days for that one before I was back on the ice. It was the last week of the season, though, so I only played for about a week. And then the second one, 10 months apart, was in another practice. That one, I got knocked down by 2 of my teammates, and I fell backwards and hit the top back area of my head. We'd had 3 team concussions already that year, not including myself, and my coach's advice was to get back out on the ice, so I played for 10 more days until I went and saw a doctor and was diagnosed with a concussion and said I'd be out for 2 weeks, and it's been 7 years. If that answers your question.
Thank you, Mr. Chair. And the next question will be for Dr. Chen. With regard to what I've just heard in terms of diagnosis, seems like it's a bit nebulous in terms of concussions. What would this study do in order to afford a more definitive approach to diagnoses?
This study would initially just determine what use and definitions are being used. There's great debate amongst the scientific community about what defines concussion. It's one of the reasons that Mayo and others are trying to use biomarkers rather than some of the behavioral assessments we have. I doubt that we would take any stand on a particular definition, but we would try and balance concerns on both ends. And there's concern on one hand that some definitions are overly broad. Some physicians will tell us that they're concerned that everything is being labeled concussion. On the other hand, there's concern about too narrow a definition, that some things aren't being marked as concussion. So what all this group would do would go out and gather the data, try and figure out where we stand, what the incidence rates are, what types of definitions are actually being used, and compare that to what's happening nationally and kind of where the gold standard is. And we would ensure that the working group has these diverse perspectives on it.
Thank you, Mr. Chair.
Other questions? Seeing no other questions, House File 1714 is laid over for possible inclusion in the omnibus bill. Thanks, Representative Zerwas.
Thank you, Mr. Chair.
Next up, we have Representative Bahr with an H. House File 1188.
You have to wait.
What? You were going to be next?
It's on the list. Everything's been in order. Take a deep breath now.
Welcome to the committee, Representative Bahr. I will move House File 1188 be held over for possible inclusion in the Health and Human Services Omnibus Bill. I see no amendments or fiscal notes in the packet. 1188 is before the committee. Welcome to the committee.
Thank you, Mr. Chair and members. House File 1188 simply changes the reimbursement mechanism, clarifies language, and to get into the details of that, I will refer to my testifier.
Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair, Committee. My name is George Burrell. I'm a manager with Anoka County Social Service and Behavioral Health Department. Thank you for allowing me the opportunity to speak to you in support of this bill. To give you a little background, group residential housing is authorized on an individual basis by applying for cash assistance with the County Economic Assistance Department. It is common for homeless shelters to rely on group residential housing for a significant portion of their funding to pay for the room and board costs of the adults staying at the shelters. The only adult homeless shelter in Anoka County utilizes group residential housing to fund a portion of its expenditures of the 66-bed facility. During state fiscal year 16, Anoka County Economic Assistance Department processed a total of 717 paid transactions for group residential housing at our homeless shelter, for a total of $371,000. Anoka County employs 1.5 FTE financial workers just to process the group residential housing applications for our one adult homeless shelter. If approved, this bill will allow the Department of Human Services to make a cost-neutral transfer of group residential emergency shelter funds to county human service agencies with existing shelters. The funding will be allocated annually and adjusted according to the percentage change in the group residential housing room and board rate. Counties can opt in or choose to continue to use individual client eligibility for group residential housing payments at their shelter. For those counties that opt in, a biennial plan will need to be submitted by the county to the DHS Commissioner for approval before any transfer occurs. The DHS Commissioner or a county may return beds to the Group Residential Housing Fund with 180 days' notice, including financial reconciliation. The outcomes we hope to achieve are an increase in financial stability for emergency shelters who rely on this funding, and administrative simplification will decrease costs associated with management of GRH for emergency shelters and for counties. Thank you for the opportunity to speak about this bill.
Thank you for your testimony. Is there anyone else in the audience who'd like to testify on House File 1188? Seeing none, we'll open it up to member questions. Member questions? Final thoughts, Representative Bahr.
Final thoughts, I will leave you with my requisite freshman first hearing treats and with a favorable referral on the bill, Mr. Chair.
Excellent work, Representative. We appreciate that, as always, and thanks for coming to Health and Human Services Finance. With that, House File 1188 is laid over for possible inclusion in our finance bill. Next up, we have Representative West, House File 1130. I will move that House File 1130 be laid over for possible inclusion in our Health and Human Services Omnibus Bill. House File 1130 is before us. Representative West to House File 1130.
Thank you, Mr. Chair. House File 1130 is a small appropriation to help Anoka County recruit foster families. And we've seen a 70% decrease in our foster families in Anoka County. So this is an incredibly important bill to my district and my community, because I don't know if that line's going to continue in that direction, but we need to look at some new avenues in order to recruit more families so we can get these kids the help they need. And I don't think this is enough to solve the problem, but I think we'll be able to find the best practices and really be able to turn it around in a cost-effective way going forward. And I have testifiers with me today, Jerry Peterson and Lisa Walter.
Welcome to the committee. Please introduce yourself for the record and proceed in whatever order you like.
Mr. Chair, members of the committee, Representative West. I'm Jerry Peterson, Director of Social Services and Behavioral Health in Anoka County. And I'm here with Lisa Welter, Community Care Director from Eagle Brook Church. Thank you for the opportunity to talk about our bill. Anoka County staff have always been encouraged to think outside of the box when it comes to helping our residents. House File 1130's goal is to identify and enhance family foster care recruitment and provide some administrative simplification through local non-traditional partnership efforts. As many of you may be aware, and as Representative West has indicated, there's been a statewide decline in accessible family foster care. Anoka County alone experienced that 76% decline in traditional and family foster care over the last several years. And although there is a statewide shift to relative care, which is a good thing, the demand and need for non-relative care still exists. Current recruitment models have not been effective in keeping up with foster care demand. Our bill does not attempt to address all the issues related to traditional foster care decline, but in a simple and hopefully inexpensive way, our plan has been to find some assistance to engage with local non-traditional partners to produce a sustainable and replicable model for family foster care recruitment. We've been engaged with Eaglebrook here for a little while, and they have stepped forward. And I want to turn over the testimony to Lisa. Okay, Mr. Chair.
Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair and fellow committee members. I want to personally thank you for taking time to consider Anoka County's innovation. My name is Lisa Welter. I am the Community Care Director at Eaglebrook Church. I'm also a licensed pastor. I set direction and create strategies on how our church will engage in our backyard community efforts. I'd like to share a quick story of how we have been led on a surprising innovation path surrounding foster care while using non-traditional partnerships. The hallmark of our success has been collaboration. Last year, over Easter, I made my way out to the Lino Lakes Juvenile Corrections Facility. I was delivering donuts and hot chocolate to the youth and staff over the Easter weekend, and while I was on site, I learned of a 12-year-old who had been in foster care in their facility since that fall. This was what I had learned, an overwhelmed situation of the system that was trying to do the best they could with the resources that they had, and yet there were unintended ramifications on our vulnerable kids. As a pastor, it took me a while to connect the dots that our society's challenges connected greatly to the way our community supported the child welfare system. In my research, I learned that there were plenty of great agencies doing compelling work, but independently, no one truly collaborating in their programming. Not because they didn't want to, they simply were drowning by the demand and didn't have time to consider a different way. I saw that as an opportunity and invited Jerry Pierson from Anoka County, Safe Families for Children, which does early intervention, and the YMCA Host Home program together to discuss an idea of working together. I've crafted a formula across the spectrum of child welfare, including early intervention, foster care, adoption, and youth transitioning, and specifically inviting the faith community to open their homes to hurting children across this entire spectrum. We recruited for homes, and we looked for those that were interested in resourcing those homes with meals, basic needs, babysitting, gift cards to ensure that those that chose to open their homes would have successful placements. We then tested this model twice and successfully recruited 90 homes and 100 families in small groups to resource those homes. We had an 80% response rate during our 2 beta tests. Normally, typical church engagement for food drives and backpack drives is around 10 to 20%. So this was a game changer in our arena. We concluded that the faith community does deeply care about our vulnerable kids, about foster kids and those that are wards of the state. We spring into action, the church does, when opportunities are clearly presented, and we see the faith community as an ideal audience to be recruiting in this hard work. It is our intent to now invite as many churches or faith communities as possible to see lasting change in our communities through this spectrum of child welfare, through a toolkit that we've been designing, including a documentary to share with anyone who's interested. When the faith community is educated and provided with easy on-ramps to engage through non-traditional partnerships, we will see a return on our investments, and we will not turn a blind eye to our vulnerable kids. We simply won't, and we can confirm that historically with international development and orphan care. The work we've already done as a local faith community, our social services agency, and selected nonprofits have created a hopeful scenario and efficiencies as we each play our unique roles in the community. This conversation has made larger traction, bringing Anoka County pilot agencies to the table of Minnesota's DHS office, MinAdopt, the Greater Twin Cities YMCA, Aspire Minnesota, who supports our many private foster licensing agencies, along with several others, creating a newly born initiative called Connected Kids. You've heard it say it takes a village to raise children. We believe that is very much the case for our children and child welfare. County experts, nonprofit agencies, and local faith communities can join forces and do it without compromising our primary mission while seeing much better outcomes for our great state of Minnesota. Thank you.
Thank you for your testimony. Is there anyone in the audience who'd like to testify on House File 1130? Seeing none, member questions? Seeing none, House File 1130 is held over for possible inclusion. Thank you to Representative West and testifiers. Thank you. All right, next up, House File 885, Representative Metsa. Well. Welcome to the committee, Representative Metsa.
Thank you, Mr. Chair.
I will go ahead and move House File 1185 be held over for possible inclusion in the Health and Human Services Omnibus Bill. There is a fiscal note in the packet, and I see that you have some testifiers, Representative Metsa.
I do, Mr. Chair, and I appreciate in the policy committee that you handed this out, and seeing as you have the gavel, I will not let you do that.
You sure?
In your own finance
I'm happy
committee.
to help.
I will get it out to the
We're all about customer
table.
service in Health and Human Services Finance Committee.
We appreciate that, Mr. Chair. And thank you, Mr. Chair and committee members. This is a bill that kind of spurred locally the last few years, and we've been trying to figure out a way. It serves, it's a women's shelter called Catherine's House, and it serves a lot of local residents. Essentially what we're looking to do, we don't quite meet the qualifications for funding at the county level at the rates that would be equal to what some other rates are given to other local providers for the similar services. And what this bill would do is allow the county to negotiate with Catherine's House for a rate up to $700 for the services provided and described in the bill. With that, I think that's the basics. We do have a fiscal note. It doesn't look to be too terribly large. And I know we're dealing with a lot of budget maneuvering here, especially in this committee moving forward, so we do appreciate the consideration. And for the members that weren't in policy, I will turn it over to my testifiers here, who will do a better job of describing why it would be a great thing to fund this year.
Thank you, Representative Metsa. Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair. Shelley Holmes, I'm the founder and owner of Catherine's House. In the previous handout that we gave out as kind of a brief breakdown, Catherine's House is a licensed board and lodge with supportive services, currently rate 2. I decided to license it that way because that what made the most sense at the time. However, my goal was to provide supportive services so that we could create our Lotus strategy that we have. We have a licensed psychologist on staff, 40 hours a week in excess of that with an RN and an LPN, which a typical board and lodge is required 4 hours a month. I guess the difference between the other board and lodges is that it's housing with meals, safe, housing. And ours is a very unique program for the women to be with their children. We have a furnished apartment in our 428 building next door, and that is so that they can have supervised day and night visits. The whole goal is for the reunification of their children and get the children out of foster care. We've had 113 women residents since we opened in August of 2015, and 90% of them had children in foster care. And so a big goal that I have, my staff, the county, Mr. Metsa, and other local supporters, is that we help these women get reunited with their children, reunite the family, And so the cost, though, to furnish, clean, supply food and activities for these women with their children, that ends up to be costly when you're talking 35 women and visits every day. We have a horse farm 5 minutes down the road for gardening, outdoor activities, equine-assisted therapy. But equine-assisted therapy in this setting is not billable to bill out to insurance companies. I use it as a tool to get the women to get out into the country and do something different that they're not used to. And with the mental health and chemical dependency issues that they have, they work with the horses and learn to trust again and realize that they can accomplish things. And it's been we've had a really good outcome. Our psychologist goes out to the farm with them, and then we have helpers and resident aides. The high cost of the medical, as I mentioned with the RN and LPN, we have 70% of them come in with hepatitis C, and we recommend that they do the treatments, and we help them through all of that. We do life skills groups every day, throughout the day. The transportation in our area is huge. The lack of it, I should say. I have some vans that we bought, and we have people that are approved drivers. But the cost of the gas, the driver, the women need to be taken to court visit, doctor's appointments, children's visits, and I'm paying that all out of pocket so that we can transport them all over. The other item is that there's such a high number of people, women that come in that are on SSI or RSDI, so then the GRH only pays a portion of their stay. And these women have mental health issues, and the only thing that they find that they have left in this life is that money they get every month. And so when they don't want to part with that money, so they won't pay their portion, and yet I'm not able to evict them and just put them on the street. So for a couple of months, by the time I give a 30-day notice, I've absorbed all of those costs. And what then I'm finding is, okay, then we get to about the 60-day mark, and it's time for them to now leave because they didn't pay. And all of a sudden, the mental health was working, the equine-assisted therapy was working, the safe home, the environment, the trust level is there. And all of a sudden, they say, oh, I want to stay. This is the first time it's been working for me. And now they start paying. But I've absorbed and lost those costs for that couple of months. And it may sound, I lose now about $30,000 a month to prove that this last 18 months was a success story, and Cindy here is one of them. I have many that have, it's worked out, it's done wonderful things, but with this difference in money, we can do all the services that I'm providing, and we can provide even more. Not sure I should let Cindy Brown is one of our success stories, and I'll let Cindy explain. She came to us, and MACV is the agency that notified her about Catherine's house and provided a portion of her rent in addition to the GRH for the first couple of months.
Welcome to the committee, Ms. Brown. Please proceed with your testimony.
Thank you, Mr. Chair and council members. I am very honored and privileged that I have the third opportunity to speak in front of such honorable members today as I do. This is a very rare and unique opportunity for me. I came to Catherine's house last year in July. I had left treatment. I had gone there for drug use, and I was homeless. I had no place to go. And up on the Iron Range, it's not safe for women on the range. It's not. If you don't have a safe place to go, it's very dangerous. Virginia might be a small town, but the crime rate is very high. I had friends I could go to, but it was not safe. They were using friends. So I called MACV, and because I'm a Marine, I'm a former veteran, and they suggested Catherine's house. I came to Catherine's house, and I had nothing but a suitcase and a clothes basket of my belongings. That's all I had left to my name at that time. When I got to Catherine's house, I didn't know what to expect. I didn't think, oh my gosh, I'm going to this safe, sober house. I had no idea. When I walked in, I felt at home. Her place is unique and different because it's not a room and board, it's a home. She provides home-cooked meals, staffing, everything that a person would have in their home. And a lot of the women that go there have never had this opportunity before. They come from very poor backgrounds. They don't know what it's like to have a safe place to live. Now, when I started staying there, I started seeing the psychologist, Steve, that helped work through my issues. I then have got a job at Blue Cross Blue Shield. I'm a customer service rep. I'm successful at my job. I get recognized quite often for my level of customer service. I'm very proud of myself, but if I did not go to Catherine's house and met Shelley, I wouldn't be here today. I would be dead. I know I would be dead. There is no way I would have stayed sober. There's no way I would have became a strong, independent woman that I'm becoming now. Because of Shelley's facility and her excellent care and her want for women to be safe, many women like me are alive and well. Now, the apartment she has upstairs is an excellent place. I mean, we can see and visit our children there in a safe environment. We don't have to expose them to the outside world that we lived in before. Now, the horse therapy that she's talking about, I'm going to be doing that this spring with my oldest daughter, Lena. I have twins that are 12, a boy and a girl, and a little one that's 6. My daughter, Lena, is so excited about going to ride horses with mommy. And this I can bill through my insurance at Blue Cross Blue Shield. That is a rare opportunity that I get to reunite with my daughter because of my years of using and drug abuse. My children, I lost touch with them. I want them to be proud of me and be able to see me for who the person I am, not for the person I was when I was using. You look at me now, and I know you wouldn't be able to tell that I was, but when I came to Shelley's house, I weighed under 100 pounds. And I was on methamphetamine. I did it the worst way you could. I mean, I'm ashamed of what I did, but I'm proud to say that I am who I am now, that I've come this far and that I've accomplished so much. And if it was not for Shelley and her excellent idea of saving women, I wouldn't be here. I do owe so much to Shelley, but yet a lot of it I did on my own because I had that drive to become the person I should be, who I was before I started using. And my bosses at Blue Cross gave me these days off to come down here. And they're proud that I am speaking in front of the House and in front of the Senate and the Finance Committee. They are very excited that I'm doing this opportunity. Because a person like me, who has the opportunity ever to do this? I don't know of anybody ever that has had this opportunity. I mean, I'm so excited I brag to everybody that what the chance I've got to do this. But I thank you for listening to me, and I thank you for your time. And I hope, Shelley, I hope this bill gets passed because there's so many women out there on the range and all over. People come not only from the range, they come from other states, other counties. Sex trafficking is a big thing. And this, because of her place, she's saving lives. And that's an important thing. So few people do that. Thank you for your time.
Thank you for your testimony, Ms. Brown. We do appreciate that. Is there anyone else in the audience that would like to testify on House File 885? All right, we will close that. Member questions? Representative Lunan.
Thank you, Mr. Chairman. First things first, you got to take care of yourself and get clean and the work and actually the time it takes to do that. My question would be, the people that live there, now you're employed now.
Yes.
The people that live there obviously have the opportunity for employment. The schedule allows that. And are all of them working?
Ms. Holmes.
No, they're not. Of 113 that we've had, 111 have mental health issues. It's a requirement in order to qualify for the GRH is to have the disability. We encourage supportive employment and have a lot of connections with people, and we try to get them out there to do that. There are so many that when they first come, especially, they're not able to do that. It is a goal in the way Cindy lives in our apartments that we have. We call it our Phase 2, and that's where she talked about now she comes and gets supportive services now through her Blue Cross insurance. She can bill out for different things. When she was in Catherine's house, when she came in, her goal always was to get back to where she was in life and shoot 2 degrees, it's in the military. We have people who come that have never had a checking account in their life. They've never, maybe some of them never had a job coming from history. But we do encourage it, but they get to keep the first $65, I believe, if I'm correct, of their money they earn, and then they give half of it goes back to reduce the GRH, and they only get to keep half of the check. And, but yes, we do. A low number goes actually out. We try, we encourage, bring them to interviews.
They're just not mentally capable of employment yet when they first come there.
Some go and they last 2 or 3 days.
Representative Luna.
Oh, thank you, Mr. Chairman, and thank you for that. And the reason I bring that up is because in our conversations around here, we hear a lot about workforce shortage, and then we take a look at a lot of the programs, the good we're trying to do here. And to the testifier, Ms. Brown, the things that you have been through actually have made you more, have made you something that a lot of people in this room are not, and that we hope that you come back in as a resource to kind of be the light at the end of the tunnel for other people, and possibly do it through some of the programs that we're funding here. The situations you're looking for are actually looking for you, too.
I thank you, and I have volunteered. I've told Shelley that I want to be a mentor at Catherine's house, and she's opening a new treatment facility actually right next to my apartment, and I want to go there and help people coming in. When people first come in for treatment, they're scared, they're confused, they don't know what to do. I want to be there and show them that this is what you can be. You can become better. You can become a person again. And if they don't think they were a person before, I can definitely help them try to become the person they want to be.
Thank you. Representative Loeffler.
Thank you, Mr. Chair, and it sounds like the programming is working for many of your residents, and that's what we expect. But in asking for a supplemental rate, I noticed that you do have a somewhat unusual range of services. You're serving less than your capacity, although it sounds like you want to grow. And you also own and maintain a farm, and the information provided here says the cost to maintain the farm, the horses, transporting, providing staff for that is an extra burden. That's not something we would typically pick up with in group residential housing. That's not the kind of supportive services, housing, room and board that we expect. And, you know, can you break down for us what the farm components of this request would be?
Oh, let's see. I see 52,000 for 18 and 117,000 for 19. Is that something you could supply the committee afterwards, if you could respond back? Just a basic percentage, something like that.
Okay, so
we don't need it now. You can email it back in. We'll get you the
So
contact
a breakdown of what the
information.
farm and the horses cost, and then the actual cost of running the home, and then the facility next door for the...
Just in basic terms, that'd be great. Thanks. All right, Representative Pinto.
Thank you, Mr. Chair, and I want to thank the testifier. Thank Representative Metsa for bringing this forward. The testifiers. I work outside the legislature as a prosecutor of gender violence, domestic violence, and sex trafficking and exploitation. I work with folks in your area on that, and appreciate it. I want to just, as a comment, though, as I'm looking at this, and I don't have familiarity with this, kind of this area of our statutes, our funding, but it looks like the way this works is that we have typically kind of picked specific facilities like this to provide the supplemental rate, and I'm very supportive of this, but just kind of wonder, it seems like a good opportunity to say it'd be nice if we had a system rather than picking specific facilities. I'm seeing just in some of the other provisions in the same area kind of specifying the number of beds and exactly where they are, et cetera, if we had more of a general setup and general approach to this rather than having to have specific facilities come and ask us for funding, but instead just recognize the good work that you're doing and have that already be built in. So that's something that I guess I'd like to explore as we go forward, because I'm just seeing a whole bunch of kind of exceptions to supplementary rate for facilities all over the state, county by county by county. So thank you, Mr. Chair. Thank you, Representative Metsa.
Thank you, Representative Pinto. And Ms. Holmes and Ms. Brown, thank you for coming back to testify again. I know for the people who are on finance but weren't on policy, I'm sure they are very glad that you made another trip. And we had a lot of very positive comments about your earlier trip down. And so thank you, Ms. Holmes, for all your good work. And Ms. Brown, thank you for your service and good luck. All the best with your recovery.
Thank you.
Thank you. With that, House File 885 is laid over for possible inclusion in the Health and Human Services Omnibus Bill. Next up, we have House File 1380. Thank you, Mr. Metsa. House File 1384, Representative Pierson. Let's see. Moves House, well, before he does that, I think Representative Zerwas is going to move, oh no, all right. Representative Pierson moves House File 1384 for possible inclusion in the Health and Human Services Omnibus Bill. Welcome to the committee, Representative Pierson. To your bill.
Thank you, Mr. Chair. Thank you, members of the committee. Olmsted County in our region is got a great facility in the Adult and Teen Challenge program that we have in Rochester. And this is GRH for the treatment services that they provide, and I have testifiers to give a little better description to color in the lines.
All right, House File 1384, proceed in whatever order you like.
Mr. Chair, my name's Tim Walsh. I'm the Vice President of Minnesota Adult and Teen Challenge. I want to allow plenty of time for our residents because they speak to this much better than I do, but I do want to highlight some things in our request. The first of all is the Department of Human Services has cataloged all of the GRH services that are provided across the state, and we look at what Teen Challenge does. We provide almost the entire menu of GRH services. So that's not just housing, but supports and treatment services. And that's why we have in the past and are currently asking for the exception rate. The other thing is, as we look at research, longer is better when it comes to getting better outcomes. And so we provide a 13-month program, and so it's a whole continuum of services that starts with intensive treatment, but also then helps clients to rebuild their lives, transform their lives, then transition and live independently and self-sufficiently after that. And we do it at a cost that is less than housing somebody in prison. And as we look at our outcomes, I think that we have lots of indicators that we have really good outcomes with our clients for the kind of investment that you make for them. So with that, I want to pass this to our residents to speak to their experience.
Welcome to the committee. Please introduce yourself for the record and proceed.
My name is Veda. I'm a client at Teen Challenge. I'm 23 years old. I came from a really dysfunctional background. My parents were really young when they had me. I never really thought I had a chance at becoming anything successful. I started using at age 12, drinking and smoking weed, and then it quickly progressed in meth and heroin. I spent most of my life in and out of group homes, foster homes, juvenile detention centers, prison, and jail. I came to this program because I got to see the live transformation of my twin sister and how she really, this program helped her change. And I guess I just decided to give it a chance, and I haven't looked back since. I just celebrated a year clean, and I never thought I'd ever be able to say that I was even a day clean without being incarcerated or forced to do it. And the moment I walked through the doors, the people just loved me exactly where I was at. They met me where I was, and they love us even when we're hard to love, and correct us when we need to be corrected. This program is really strict, and it's what somebody needs that's spent a lot of time in that dark lifestyle of doing drugs. And I'm just honored to be able to speak on behalf of this program. It says a lot in itself that I would even be willing to do this, because my heart is for this place. And thanks for listening, and
Thank you for your testimony. We do appreciate it. Welcome to the committee. Please introduce yourself and proceed.
Thank you. My name is Victoria Liebel. I am also a resident of the long-term program at Minnesota Adult and Teen Challenge. Prior to coming to Teen Challenge last April, I had been to over 10 treatments, the longest being a 30-day program. The last year of my addiction, I was using heroin every day. And on March 28th of last year, I lost my boyfriend to a heroin overdose. And if at that time, I realized that if I continue down this path, I'm going to end up in the same place. So I knew that I had to do something different because the treatments that I had been to didn't provide for me the life transformation that I knew that I needed to be able to survive. So I decided to come into Teen Challenge because I had heard such amazing things about the program, and I knew people that I had used with that no longer used and were living in freedom. I am getting close to graduation, and I can honestly say that this program has transformed my life. I know how to live, and I know how to handle myself, and I know what I'm here for, and I have such a passion to help other addicts, and I also plan on staying with this program, and I'm actually going to be finishing up school and plan to come back and then give to other addicts through this program. So.
Thank you for your testimony.
Thanks.
All right, is there anyone else from the audience who'd like to testify on House File 1384? Seeing none, we will open it up to member questions. Representative Pinto.
Thank you, Mr. Chair, and just the same as the prior one. I first want to thank our really powerful testifiers for sharing your experiences. Thank you, and to Representative Pierson for putting this forward. I understand from Representative Liebling that in the Reform Committee that she had brought up the point about kind of having a broader framework for these specific supplemental rate increases, and I guess that just presented a question for me. I was noticing that most of the other ones have a maximum supplementary rate of $700 per month. That included the bill we just heard. A couple do have higher than that, and I'm just wondering if there was a particular reason that the rate was as high as $750 as opposed to $700 for most of the other exceptions I saw, but again, not all.
Do you want to take that?
Mr. Walsh.
Mr. Chair and Representative, there's a whole range of exception rates that are provided, and DHS can certainly, I imagine, get you the detail on that. And the range, as I looked at it, goes even over $5,000 for an exception rate. But of course, those are people with, I think, medical needs and severe physical disabilities. We took a look at similar services, similar facilities, and looked at what they were getting, and that's how we landed on the $750. By the way, that only covers less than 50% of our total costs, and the rest of our costs are provided through our generous donors to our capital facilities and other operations.
Okay. Thank you, Mr. Chair.
Representative Fisher.
Thank you, Mr. Chair. First of all, I want to thank the testifiers, the young ladies, for their testimony. It was very good. One of the things I just want to clarify, following up a little bit on Representative Pinto, I know that on the previous bill we heard they were listing across what they were looking at for GRH before they received the $700. I saw that they were at $1,374, which is the base rate and the first supplemental rate on top of that. And I wasn't seeing additional information here. So when I see the $750 that's being requested here, is that on top of the base rate of the $891, or is that on top of the base rate plus the other supplemental rate for a total of $1,374?
Mr. Walsh.
Mr. Chair, Representative, you take the base rate of $891 and then you add to that $750, and that's the total monthly rate per client that we're asking for.
Okay, thank you. That was my question.
All right, other questions? Seeing no other questions, House File, or Representative Pierson, last word.
Yeah, I guess I would just add, this specific facility in Olmsted County is one of I think it's the only adult and teen challenge program that doesn't currently receive the supplemental rate. So that's really kind of what we're emphasizing and trying to adjust, and would hope that the would be included for, or considered for possible inclusion.
Thank you, Representative Pierson. With that, House File 1384 is laid over for possible inclusion in our omnibus bill. All right. Next up, we have House File 1402, Representative Allen. Representative Allen moves House File 1402 for possible inclusion in our HHS omnibus bill. There's no fiscal note in the packet and no amendments. Welcome to the committee.
Thank you, Mr. Chair.
Presentation, and proceed with your bill.
Mr. Chair, members, this bill appropriates $200,000 from the Department of Human Services for a grant to the Minneapolis Crisis Nursery, and I have a testifier here.
Welcome to the committee. Please introduce yourself for the record and proceed.
Good afternoon. Thank you, Mr. Chair. My name is Mary Pat Lee, and I'm the Executive Director of the Greater Minneapolis Crisis Nursery. The mission of the Crisis Nursery is to end child abuse and neglect and create strong, healthy families. We work to achieve our mission by providing a continuum of care to families at risk of child abuse and neglect. These services include access to 24-hour crisis line, respite care for children aged newborn to 6, home visiting services, and most recently, in-home mental health services. Currently, our services are available to anyone in Hennepin County, but the reality is that the vast majority of our clients are families living in extreme poverty. Last year, 84% of the families we worked with had incomes of $10,000 a year or less. We believe that the families who use our services deserve and need the best possible care we can provide. To that end, we are reaching out to thought leaders, practitioners, and scholars to ensure that our work incorporates the best practices and most current research available in our field. Today, we have strong working relationships with allies at the Institute of Child Development at the University of Minnesota, the School of Social Service Administration at the University of Chicago, and the Center for the Developing Child at Harvard. These relationships have allowed us to improve our care protocols and create outcome and evaluation standards. Our mission is not to end child abuse and neglect and create strong, healthy families in Greater Minneapolis. Our mission is to end child abuse and neglect and create strong, healthy families, period. We believe that the best way to achieve this mission is through partnerships and collaborations with other organizations throughout the metro area and the state that are also serving families and children at risk of abuse and neglect. We believe that a network of agencies using a consistent approach to practice, committed to best practices, and collecting consistent data could be a powerful vehicle for achieving our mission. To that end, we are working now to develop a system for exporting our trauma-informed care protocols, the Nursery Way, to other organizations. Hopefully you have a handout describing our Nursery Way care protocols. The Nursery Way is an intentional, developmentally, and trauma-informed intervention that provides security, restores predictability, soothes trauma-related arousal, and provides care that helps children and strengthens families. These care practices promote resiliency for both the child and parent and lead to further prevention of child abuse and neglect. House File 1402 is a request for $200,000 to support the Crisis Nursery's efforts to develop and export the Nursery Way care protocols to other agencies in Minnesota. To put this request into perspective, let me point out that last June there were 1,569 children in the foster care system in Hennepin County. 38% of those children were age 0 to 5. The county spends an average of $300 a week on child care for children aged 0 to 5. So for the approximately 600 children they had in foster care in June, 1 week of child care would cost $180,000. We hope you will join us in our effort to end child abuse and neglect and create strong, healthy families. Thank you very much.
Thank you for your testimony. Is there anyone from the audience who would like to testify on behalf of this bill? Seeing none. Member questions, Representative Haley.
Thank you, Chair. Just a quick question. Can you tell me if there's any connection between crisis nursery and family home visiting? We also heard a lot of bills this session about that family home visiting programs. Just curious.
We have a home visiting program at the nursery. It's part of the continuum of care that we provide. I don't know if that answers your question.
Are your clients also served by other county programs, though, where they are getting home visiting from, birth?
We don't provide home visiting if the family already has a home visitor because we find that it's too confusing to the client.
But your clients are receiving some of those services as well?
They wouldn't be receiving in-home home visiting services if they were getting them from us. But yes, we have clients who are receiving other county services.
Thank you.
Representative Pinto.
Thank you, Mr. Chair. I had the chance to do a tour of the crisis nursery, and if other folks have not had the chance, I really encourage it. It's a pretty amazing place, and just want to point out the statistics that 85% of the clients live on less than $10,000 annually, nearly half homeless. This is absolute child abuse and neglect prevention money and work, and so thank you for your work. Thank you, Mr. Chair.
Thank you, Representative Pinto. Representative Lunan.
Thank you, Mr. Chairman, and I do think this is an important topic, and when I saw this bill come through, Representative Allen, I went and looked in my district. We have a crisis nursery, and our model is a little different in that we have a collaborative with daycares and nurseries in the district that they use those as a resource. We don't have a facility at all, but using those, and they've found that that's been very effective. My question is, your sources of revenue, where all does the money that you folks need come from?
We get about our budget is $3.2 million. We get about $600,000 from the county, and the rest of it is primarily philanthropy, individuals, corporations, foundations.
Well, I would like to work with Representative Allen going forward with that part of it. There are people out there that are looking for situations like this to get involved in.
It'd be great. Thank you.
Representative Liebling.
Yeah, thank you, Mr. Chair. And I also, I haven't been to visit this one, but I know in Olmsted County, where I'm from, they also have a crisis nursery program that is very successful. And so I just, a couple of weeks ago, not even, was able to welcome a new grandchild, which is my first. So I'm watching my son and his wife dealing with their newborn. And it just reminds me of how incredibly difficult and stressful it is to be a parent, even under really good circumstances. So I think, and I actually asked my son, does it make him think about what people are going through when they don't have that sort of support? And, I think it's those of us who remember what it's like or have recent experience watching someone go through that when we think about what it would be like if you didn't have any support. And so I also was looking at your statistics, and 93% are single parenting moms. And they're in poverty, and. So, this is something that if we lived in a world where everybody had grandparents nearby and, surrounded by family and, didn't have all those additional stresses, maybe we wouldn't need this, but we do, and it's just so critical to have this kind of support for those families, and I just think this is one of the best things we can do. If we're talking about families that have less than $10,000 annually, we're probably talking about a lot of that same population that's on our MFIP program that we were talking about recently in this committee, and I just think that this sort of help, a place to go when you are just desperate, and not only that, but some guidance and some help to figure out how to go forward from that moment is just absolutely indispensable. I really hope we can fund this. Thank you.
All right, thank you. Representative Allen.
Oh, just Thank you, Mr. Chair. Just respond to a couple of the comments. Thank you, Representative Luna and Representative Liebling, for your comments. And this is something that what Representative Luna, you were talking about, the purpose of this grant would be to take this model and so that it can be duplicated in other areas. And I think to your point, Representative Lee, when you're talking about the need in other areas in greater Minnesota, or that, sort of thinking of how poverty and homelessness and families, if they're low income, oftentimes that may be because there's not two earners in the household, but how poverty and homelessness can cause stress on children and cause trauma, and that and so there's a letter in here. It does a good job of stating that the crisis nursery will work with the Center for the Developing Child of Harvard University to develop the model that can be exported. And then I also just want to know that this crisis nursery center has been in the district I represent for 35 years, and I know of a few family, at least one family I know that benefited, who some of my family came from, lived in Little Earth for a while. And I know that as one of my nieces had a child when she was young, and she benefited from taking her child to crisis nursing. And I think it is something that is to prevent child abuse, and it's very effective. And it was a model that was recognized and vetted during the meetings for the Child Protection Task Force that Representative Krisha chaired. So thank you.
Thank you. Other discussion? Seeing no other discussion, with that, House File 1402 is held over for possible inclusion in our Health and Human Services Omnibus Bill. Next up, we have House File 1522, also Representative Allen. Representative Allen moves House File 1522 be held over for possible inclusion in the Health and Human Services Omnibus Bill. There is a fiscal note attached and no amendments, Representative, to your bill.
Thank you, Mr. Chair. We're back to the GRH bills. I think there's a couple more here. This bill here would increase the number of beds under the current moratorium on development of group residential housing beds from 190 to 226 for supported housing units for homeless adults with a mental illness, history of substance abuse, or HIV/AIDS in Anoka, Dakota, Hennepin, or Ramsey County. And I have a testifier, Mr. Chair.
Welcome to the committee. Please introduce yourself and proceed.
Thank you, Mr. Chair, and the opportunity to speak with you today. My name is Chuck Pierson, and I serve as Executive Director at Clare Housing. We're a 501c3 nonprofit organization whose mission is to ensure that all people living with HIV have access to affordable housing and the supports needed to maximize their health and housing outcomes. GRH has been a lifeline for many of our long-term homeless residents, but the way it's structured currently doesn't always provide for the opportunity to move out of poverty that we hope it will, as well as to allow individuals to live independently. And there's three ways in particular the market and outside forces have limited its current effectiveness. First, GRH was originally designed to be used in a group setting where someone took care of all their basic needs and controlled their funding in order to do so. It wasn't designed for independent living, something we all know is a key towards self-sufficiency. Second, rental subsidies, as you know, have stagnated, and as a consequence, rental supports have become increasingly difficult to obtain for those who are in particular very low income in our community. And third, an individual has to give up all but $97 of their income in order to gain access to GRH supports. And that limits choice. It limits a person's ability to move out of poverty and often results in making choices between food, medical attention, as well as other basic necessities of life. Clare Housing is proposing to take the existing GRH Metro demonstration project to scale by raising the cap by 36 units. It's been an incredibly successful project that's demonstrated how structuring GRH funding to be more like rental assistance can help actually move people out of poverty and can help improve long-term housing stability. We believe as a result of this small change, we'll be able to experience a higher success rate in keeping people housed and maximizing their independence, We can reduce public costs incurred as a result of being homeless and also reduce costs and realize the savings to the state as shown in the fiscal note for this bill. We strongly support House File 1522, and I appreciate you hearing it today, and I'm happy to answer any questions you might have.
Thank you, Mr. McGinn.